we've heard or seen instances where patients get heart attacks during surgery, or when the surgery is over and you want to wake them up, it takes a little bit longer. So they're exposed to medications and a machine breathing for them for a
It's a
little
little
bit
scary
longer.
to hear.
It is. It is.
UM Specialist Centre isn't your typical hospital. It's Malaysia's premier quaternary hospital where rare, complex and next-level care comes to life. This is Quaternary Care, where our team of trusted super consultants are here to take on your toughest health battles using advanced technology and research-backed treatments all under one roof. Now, back to Nadia Azmi for UMSC's QRATED podcast.
Hello everyone, welcome to another episode of QRATED, brought to you by UM Specialist Centre or UMSC. I'm Nadia Azmi, your host. Now, before I introduce who the guests are today, I have a question first off. Have you been in surgery? Have you gone for surgery? Or maybe have helped someone go through what can be considered as a very daunting experience. Now, what we sometimes don't remember is that a lot happens, a lot goes on before a surgery actually happens. Now, surgery doesn't begin in the operating room or operating theater. It starts long before with lots and lots of preparation. Now, today we're going to explore what we call pre-operative conditioning or prehabilitation, which is helping patients go through this process. And today we're going to zoom in into our elderly patients, those who need tons and tons of care from not just the medical experts, but from all of us, the family members that surround them. And we'll also narrow down into major procedures that they will have to go through, such as joint replacements. All right, now from fitness assessments to targeted exercise plans, we'll hear how UMSC is leading the way through teamwork and innovation. So without further ado, let's meet what the doctors are this time around. Now, I'd like to say welcome to Prof. Dr. Azlina Amir Abbas. She is a consultant orthopedic surgeon.
Yes.
Welcome to the show, Prof.
Thank
Azlina. Great to have you. And next to her is Associate Professor Dr. Mohd Nahar Azmi Mohamed, a consultant sports physician. Welcome to the show.
Thank you, Nadia. Thank you for inviting.
All right, now let's start off QRATED. This time the topic is about the unseen step before surgery. Wow, I love that topic. I love the title.
Drama.
So we want to know how patients are, they have to be fit for the table. When we say
Yeah.
table, it's a table in the operating
Yes.
theater. So there's a lot that happens before they actually are fit for the table.
Yep.
Before that, so I've introduced the both of you and also who you are, your expertise. Prof. Azlina, a consultant orthopedic surgeon, and Prof. Nahar, a consultant sports physician. We want to know why we have brought the both of you here together on one show. So first off, Prof. Azlina, can you explain a little, what is your expertise and what's your role when we enter the operating theater?
All right. So I'm a general consultant orthopedic surgeon, but my particular focus is on hip and knee replacements, so joint replacements. And these are two joints which are commonly replaced because patients have worn them out. And so in the operating theater, once the patient is anesthetized and positioned in place, I do an operation which opens up the joint. The damaged bones or the damaged joints are removed and replaced with implants, which allow the patients to get back their mobility, takes away their pain, and then that's it. Then I send the patients back up to the ward.
And usually for these procedures, your patients are from the elderly category, is that right?
Yeah, most tend to be older, but nowadays a lot of people, younger people, they're more active. They sometimes wear their joints out sooner than before.
All right. But for those elderly
Yeah.
ones, I mean, I know that the definition of our maybe senior citizens who have reached their golden years,
Yeah.
perhaps above 60, 65.
65, if I'm not mistaken. 65 and above. Yeah.
Okay. What about you, Prof. Nahar? I know that you are a consultant sports physician. So are your patients only among those who are athletes, or like everyday people like me who doesn't really know much or do much when it comes to sports?
There's always been a misconception about sports medicine, because I know once you talk about sports medicine, everybody will think about, you should be an athlete or somebody active in sporting activity. but they forgot that we not just looking after anybody does sports, but also any form of physical activity, or we need to prescribe exercise for those that need it.
Okay.
So the range of individuals that we seen is range from even from children to older adult. So from anybody to somebody, like athletes. So it's wide range. So from involved in sporting activity, or you just day activity like Nadia, you go for hiking, you get injured, or you want to start exercise, but you don't know how to start. And then you want to make sure that are you safe to do exercise? So that's what we do. So in patient with Prof. Azlina, we work together in terms of to make sure that patients fit for operation.
Okay, Nadia and hiking, hardly ever in one.
I was
What do you say?
Actually, I'm trying to promote you and to encourage you to keep active.
Yes, you're right. That's good. We need to promote a healthy lifestyle.
Yeah.
I mean, I think there are many activities out there that we can do that doesn't, you're not restricted to just certain activities.
Yeah.
And it can be indoors as well.
Yes, true.
Right.
Yes, you're right.
All right. Now, I've mentioned some very medical jargony words just now, which are pre-operative conditioning and also prehabilitation. Okay, we want to know what those mean in a hospital context and how it's becoming more and more important in surgical planning. Can I start with Prof. Azlina?
All right. So with prehabilitation or preoperative conditioning, when patients do come to see me and they're saying, "Oh, my knees are painful. It's difficult to walk. I haven't walked for a long time." We do know that if one has not moved a lot and regularly and kept themselves physically fit, the muscles get weak. Everything gets weak. So it affects not only your walking, your posture, etc. And when someone has been suffering for too long and you do surgery itself may weaken them even further. So preoperatively, that means before surgery, prehabilitation aims is to try and get your muscle strength as strong as possible, your physical conditioning as best as possible so that you can go through surgery.
This is all before a surgery takes place.
Yeah. Ideally, it's before. Some patients come very last minute. It's a bit difficult, but if patients do have time, their condition is tolerable for them, then certainly, yes, that would be the most ideal before surgery. Because after it's like, you're starting a few steps back and then you have to build yourself up.
Yes.
That makes it a bit challenging.
How long usually is this process or this preparation that takes place before a surgery? Does it depend on the patient?
I think it does depend on the patient. Obviously, because some patients come where the pain is not that bad, they can still tolerate and they can still wait. I would advise them at least 3 months. That would be, I think, the best. Betul tak?
Yeah.
Right. So that would be the best. But there are patients who come where it's so severe pain, you want to ask them to even walk also, it's so difficult. So it'll make it very challenging for Prof. Nahar to, even initiate exercises for them. So in those instances, then we go, okay, prehab is probably not for you. Let's get your pain sorted first and then we focus on it after.
Because sometimes surgery is always the last resort.
It should.
Ideally, I mean, that's the...
Yeah, and actually knee replacements or joint replacements is an elective surgery, meaning that it's not a must do or else kind of thing. You can opt to, it's not an emergency. So you do actually have time most of the time.
I see. And when you see patients, do they come in mostly because of injuries? I mean, it doesn't have to be sports. Into sports activities, it can be non-sports activities as well. But is it because of lifestyle issues?
Yes. As I mentioned earlier, it's a wide range.
Yeah.
From any injuries, either from sports related or physical activity accelerated or none. Like, when you go downstairs, steps and you twisted your ankle, lifting something, back pain or something like that. So that also may consider, we can see also it may be overlapping with other discipline. The other thing, like when you mentioned, lifestyle. We receive a lot of referral in regards with obesity or underweight. In terms of to improve their weights or to managing their weights to get much fitter, something like that. So even patients where they have conditions like NCDs, like for example, hypertension, high blood pressure, high cholesterol, diabetes, and the physician will refer to us to prescribe some program or exercise that suitable for them.
Okay.
So those are the things that we seen and we do and encourage to improve their lifestyle,
Yes.
to minimize or optimize their life in terms of reducing the complication from the disease.
Yeah.
Yep.
And when we talk about this topic, there's also something called cardiopulmonary exercise testing, or CPET. So first of all, Prof.
What-
Nahar, what is that?
Okay, it's quite a jargon
It is.
to mention CPET. Okay, cardiopulmonary exercise testing. Okay, just imagine if I'm sure we try to imagine, most of the time we use this for athletes
Okay.
to check their fitness, how fit they are, how they have improved during their training for the past 3 months or 6 months before the big event.
Okay.
So we do a test where they need to run on a treadmill, and then they need to wear a mask.
Okay.
And we will put some electrodes on the chest, and then they will run according to whatever protocol that we choose for them to run on the treadmill. So they will run maybe 3 minutes, 6 minutes, or 12 minutes, depends on the level, until they're able to complete the test. It may complete in 20 minutes or 25 minutes. This for athletes. Yeah. So those are what we call the tests, where we will measure oxygen, carbon dioxide, and all other what we call that measures that needed to tell that this individual are fit, or in the case of patient, whether or not patients how their lung respond towards the stress. So when you ask them to do the test, meaning you are stressing them. For patient, they won't run on the treadmill, but we'll put them cycle on a bike.
Okay.
On the bicycle, but a recumbent bike where you can lean your back. There's a bicycle where we can lean on your back. So meaning that quite comfortable for them, they will cycle for a certain minutes or duration. It depends on them, how long they can cycle or they pedal. Then we measure carbon dioxide, oxygen, other measurement. And then from there yourself, we will say, oh, this patient, okay, fit for the operation. For athletes, whether their fitness level has come to the level that where the coaches want them to be before the event.
So for normal patients, this CPET is being done to test the readiness of a patient before they go for surgery. It'll give you insights whether
Yes.
the patient is truly ready or not.
Exactly.
Yeah.
All right. Now, from your perspective,
Yeah.
Prof. Azlina, why is it very important that we measure the fitness level of a patient before he or she is ready for surgery, especially for major procedures like joint replacement?
Sure. It's really important because in order for patients to undergo the surgery, they need to go through anesthesia. The backup is always general anesthetic, where they're put to sleep. There's a machine breathing for them, and if their lungs and their heart are not that great, that already is a stressor. And added on to that, the surgery, which, as you rightly put it, is major. So when it puts, even though you're asleep, your body detects the stress, and it reacts, even though you don't see it in the face, etc. And when the body reacts and your heart and your lungs can't take it, is when patients run into trouble. We've heard or seen instances where patients get heart attacks during surgery, or when the surgery is over and you want to wake them up, it takes a little bit longer. So they're exposed to medications and a machine breathing for them for
It's
a
a
little
little scary to hear.
It is. It
honestly.
is. So that's why, we this is a surgery that's meant to improve their quality of life. And the last thing we want is for them to come out of it with more problems, sicker than when they went in. And that's why things like preconditioning, prehabilitation helps patients to get out of surgery safer, I think, faster. And of course, the long term in terms of functional recovery, it's better.
Yes.
Yeah.
Now, while we do all of this prep, I'm sure you have encountered situations where a patient is actually not ready for surgery.
Yeah.
What happens then?
Okay. Well, You have to give them the bad news lah that you're not ready for it now, right?
Yeah, what from my experience looking for this type of patient where they are not ready, of course any improvement is still benefits. Yeah. Even though like what mentioned Prof Azlina mentioned regarding the duration of time, ideally the longer the better. But then for some conditions like other operation other than hip or knee replacement, some of them don't have enough time or even less than 4 weeks. So as much time that needed that we can help to improve their so-called fitness, is better than none. So it will reduce, at least minimize the stay or the complication after the operation rather than not at all.
Yeah.
What do you mean by they don't have enough time? Is there a specific timeline that a patient must adhere to?
Yeah, okay. Our body normally responded to any physical intervention like prescription of exercise to condition them before going for operation. Need about 4 to 6 weeks at least. But may good if have time. That like most of Prof Azlina patients have ample of time, so we can prep them very well before going for operation. But for some surgery like colorectal, for example, the what do you call that guts, operation, or any form of operations like liver, or they sometimes the cancers, most of the time are cancers, because when they come to us, let's say they come to our organization hospital, they have been shopping other places, and then by the time when they reach us, it's already like towards like stage like quite bad. So very short time, or either you have very short time or no time at all. So that's where sometimes when we receive referral less than 2 weeks or even less than 1 week, we can't do much, because when you do some kind of conditioning to improve their fitness, it will create stress to the body, and when they go for operation, is another stress. So might as well you don't stress them at all. But maybe you need to advise them to do some kind of breathing exercise or something like that. At least something, rather than nothing at all.
Is age a factor? Because if we're talking about dealing with elderly patients, the older they are, the riskier it is for them to go into surgery. So does age ever become a hindrance that they cannot get surgery?
I think age is not the number. The number is not important. It's the quality of the person.
Right.
We've operated on the oldest I've been involved in an operation, 99 years old.
Wow. Okay.
And she was very independent. She was living alone despite her family wanting her to. Yeah, she would go to market every day. She would cycle to the nearby market, duduk kat kampung,
Once again, lifestyle.
Yes, exactly. So a lot of patients are concerned. I get patients who are in their 60s or even 50s sometimes. I think I need to do it while I'm still young. But actually, if you're still young and your joint is still not that bad, I always tell patients, God-given is still better than man-made. If you can, tahan lagi with your condition, it's not that bad. Try and push on until you really need it. And they get worried because by then I'm older. As long as you have your blood pressure under control, your diet, your physical conditioning is great, you can come for surgery anytime. But, no rush. Don't rush into something that you don't really need.
Basically, it all boils down to the time. It requires time. It has to be the perfect timing. So time is of the essence.
Yes.
All right. Now, Prof Nahar, what does a typical prehab program look like for someone preparing for a joint replacement procedure? And at the same time, tell us, how do you balance safety for older patients, especially because some of them may be suffering from comorbidities?
Okay. So from the cases from Prof Azlina, first, she will refer.
Okay.
I will assess the patient first, understanding their background. Like physical activity background, whether they are sedentary type or maybe before that they are active. So those two will make a lot of difference in terms of how you're going to approach. And then we will assess them. We have few tests, assessment in terms of testing their fitness, in terms of their strength, and then we measures. So we do bioimpedance analysis where we measures the composition of fat and muscle. from then itself, whether or not the patient, because we are dealing with older people, so whether or not their muscle very low,
Okay.
or what we call sarcopenia. So in that case, we may need to get involved with dietitian to improve what we call that, improving their strength, muscles, and so on. But in terms of from our part, so the prescription may involve with what we call strength training. But strength training doesn't mean you have to do weights and lifting weights only. You have body weights. You have, of course, lighter weights like resistance band or dumbbell and so on. But again, to answer your question, so we will assess them accordingly. Yes, you have different level of older adults where from different background, what they can do. So we will assess what we call individually. From there, we will prescribe accordingly. So I wouldn't say, yes, we have template, okay, aerobic type of exercise, maybe start with cycling or walking, or strengthening, we add resistance band, or maybe body weight like sit to stand, or use dumbbell and so on, or you improve their flexibility, their stretching, and add on some balance training. That will be what we call that the template. But then in the end, we will prescribe accordingly to the individual itself. How much? Sometimes we will start very, very low. They don't have enough energy to lifting weights. Why you want to focus on lifting weights? You need to improve to get make sure that they have energy to lifting some to do something, to do strength training.
Yeah.
So maybe can do very light walking, for example. If cannot cycle, sometimes they are very obese. Even to walk or to pedal is very challenging. So we can do some exercise movement which involve waist and above. So we have arm cycle. So we will start with that. So it's all what we call that modified accordingly.
So sometimes it's not that straightforward for a patient to go into surgery. A lot of things need to be assessed beforehand.
Yep.
The patient needs to do a lot of heavy lifting.
Yeah.
So yeah, a lot goes on. Now, what the audience probably doesn't know is that outside of the studio of QRATED, that Prof Nahar and Prof Azlina are very good friends. We have worked with each other at UMSC, even though that their fields of expertise are different.
Yeah.
So we want to know, how do the both of you coordinate when it comes to attending the same patient, caring for the same patient? I know that Prof Nahar, you mentioned briefly just now that patients see you first for assessments, or how does the sequencing go?
Okay. It can be either way. Prof Azlina see patients first, or I will get the patient first. Sometimes the referral will be differently, not direct from Prof Azlina. So if I see patients, I will see most of the time patients, they don't like operation.
I mean, who does?
Yeah.
They come to my clinic first, and then they realize you need surgery.
Yeah.
They kind of go, no, actually, is there any other option?
Yeah.
That's when he comes
See,
in.
we need the both of you. We really do. But it's something that if a patient can, they would want to evade.
Yes.
Yeah, of course. For my part, so I will assess.
Yeah.
I will start to do conservative, and then we'll give time. Okay, when it responded well with whatever that intervention in terms of the prescription of conditioning or exercise that I prescribe is showing improvement, so we'll remain and monitor. Okay. If not, let's say patient still complain of pain, then I will start refer. If that's the case, when patient come and see me first.
Okay.
But from patients, Prof Azlina, you know that the operation date will be long. A year or 2 years or maybe 3
Maybe
years.
not in UMSC. Lah,
Maybe the example long.
Okay.
Maybe long. So then that's where the time I have ample of, prepping patient, tell them, oh, you do this, and then gradually increase and monitor them. Okay, and then maybe see them maybe in a month's time or 6 weeks time to see the progress and measures and do testing. And then once that ready, I will inform Prof Azlina, okay, I think this patient is ready. Or then we do CPET.
Okay.
Where CPET, I call it CPET.
Okay.
CPET test. So to see how fit in terms of lung and heart responded to the stress.
Yes.
because CPET is actually a test where it's actually reflecting the stress, whether or not the body able to cope with the stress.
Okay.
So it will give some overview, and then I will inform Prof. Azlina, okay, the test is okay. I think patient's suitable
Yeah.
to proceed for operation.
So what happens next, Prof. Azlina?
So what happens next is after he send them
Yeah.
back to my clinic, then we kickstart the assessment process. So pre-operative assessment is not only just a physical condition. Then you got to look at all of their other medical comorbidities. Are they truly under control? So that's when we do the whole battery of blood tests, X-ray. There's a referral to the anesthetist pre-operatively. So in the past, it used to be we admit the patients the day before surgery, then the anesthetist will see. But by that time, usually it's quite late to do anything. So now what we do is we have a pre-anesthetic clinic.
Okay.
So 2 weeks, 4 weeks before planned surgery, patients see the anesthetist. They also look through. They are very happy when they see notes from Prof. Nahar that says clear, good to go. They review also the blood test and everything, and they are also then confident that we can proceed. And that's when we get the patient ready for surgery.
Mm-hmm. And whereby it can happen vice versa as well, whereby
Yeah,
they
yeah.
come to you first, Prof.
Yeah.
Azlina,
Yeah.
then you refer them to
Yeah.
Prof. Nahar.
Yeah.
So it depends on what is it that they need.
What they need. Yeah. So there are, like I said, a lot of patients come to see me sometimes first because they have a lot of pain and they think surgery is all they need. And sometimes it's validated with the X-ray that you see. But sometimes when you talk to patients, you get this feeling that they tell you they want, but there's a little bit of resistance.
Yeah.
And if the X-ray doesn't look too bad, I actually tell patients, look, I don't treat your X-rays, I treat you. And if your pain is not that bad and you think you can wait, why not you try physiotherapy and conditioning first? And there have been occasions where after I send them on to him, they come back 6 months later and go, actually, Prof, I feel much better now. I don't want surgery. And that makes everybody happy. I'm
That's
happy.
happened. That's
That's happened a couple of times actually.
Okay.
So I'm happy with that. A lot of people think, well, surgeon will be very unhappy because then you're not doing what you love to do.
Yeah.
But actually, I think it's in the best interest of the patient, right? I think surgery does not solve all of your problems. Certainly not this type of surgery. And I think if you really need it, then yes, you'll need it. As Prof. Nahar said, if after all of your interventions and they still don't improve, then of course we'll go and do what we need to do.
Well, we love the synergy and the chemistry that the both of you are radiating. It's comforting as a patient, I think, to know that your doctors are working together in a good collaborative manner. So then, what does this collaborative care model say about UMSC's approach to surgery beyond the operating theater? Prof. Nahar, maybe you can start.
You better start first.
Collaborate, actually, for me, it's important, to do collaboration, not with surgeons only, orthopedic surgeons in this case, but of course with others like, the anesthetists, that involved in the procedures, or the dietitian, where we work as a team. So it's like a multidisciplinary team and session of discussion for the best of patient care. So it is actually very important. We have a good communication. Of course, to have a good communication, you need to have a good friends lah. Sometimes he's good, but then you don't have a good chemistry. So there are quite a number of surgeons, or you can work very well. So for example, myself and Prof. Azlina, and then we get involved anesthetists and other also.
Because a lot of big decisions need to be made collaboratively.
Yeah, exactly.
Prof. Azlina, how or can you share with us any personal cases or data that have shown where prehab can shorten the recovery time, reduce complications, or improve the surgical outcomes?
Okay. So actually, if you look it up in the internet, no need to go so far. Just ask ChatGPT what is the data say about prehabilitation and joint replacement. There are many literatures out there that says it really does help. The simpler one that I can say is this is what I've noticed in my practice. Patients who have had prehab,
Mm.
had surgery, and go back to, for example, Prof Nahar or wherever it is they had their prehabilitation program at. As soon as sometimes 2 weeks or 4 weeks after surgery, they are walking even without tongkat. And whereas a lot of patients think, oh, I have to be on a walking aid forever, or it takes a long time to heal. I've also seen patients where, let's say, they've not been part of a prehabilitation program, but post-op, they either do exercise on their own at home, which is great because I tell patients, if you're disciplined, it's great. If you're not so disciplined and you tell yourself, yeah, I will do, but you buat only very minimal, then of course the functional recovery is a little bit slower versus someone who goes on a regular basis to a program, whether it's physiotherapy or with sports medicine. So that I feel is already validation for me that, many patients that I've seen. So it's difficult for me to identify just the one for you, but I rest assured I've seen many now where if they do their physio, they're disciplined about it, they're diligent about it, then the recovery is quite fast. The fastest I've seen is someone at 2 weeks say, okay, that's it, I don't even want to see you again. They tell me they don't want to see me again. Because they say, I'm fine.
Yeah.
I don't need to come back again.
Well, that's good news. It's very reassuring
Yeah.
for patients out there, especially for those who are about to embark on this journey going into surgery.
Yeah.
Now, as a wrap-up question for the both of you,
Okay.
as we conclude part one, more hospitals are moving towards evidence-based care like UMSC. So how do you see UMSC's focus on prehab and CPET or CPET setting a new standard in pre-operative planning? Prof Nahar first, and then we can go to Prof Azlina.
CPET. Okay. This is something actually new. Yeah. Something that I wouldn't say that we started first, but in terms of pre-operative assessment and pre-operative conditioning with assessment with CPET to look at, to stratify. I mean, to see the risk, whether low risk, moderate risk, and high risk that we have done. I would say we are the one that started first.
Pioneer, definitely a pioneer.
Yeah, we started first. So and then we have many patients that being referred to us, and the outcome of this, prehab. The outcomes are good, which is actually very important. And then I would say, again, pioneer on this and work together closely with the surgeon and anesthetist is actually very, very good. And because they understand that our role, which make us important to them.
Yeah.
Prof Azlina?
I think, certainly UMSC being strongly affiliated with University Malaya, what we do is really reinforces what we teach our students, what we teach our master's trainees. And I think with prehabilitation as evidence, is why it has allowed us to even do things like daycare surgery. And you can do joint replacements, come in the morning, have the surgery, by petang you go home. And that's something that we can achieve through prehabilitation. Gone are the days where patients have to stay in the ward for days or weeks. And they can carry on with their recovering at home, which is obviously more comfortable. So I think this is where we are quite fortunate that we are able to have this opportunity. In daycare surgery, I think not many hospitals do it, for example. And especially when they are not in an establishment like ours, where we have many different specialties that we can work together.
And they're all under one roof.
Under
That's
one
what
roof.
makes it so efficient.
Exactly. So and because we work so well together on all fronts, whether it's in the university side or in UMSC, I don't know. For me, I never look at each other as competition.
Yep.
Like if his intervention takes away surgeries from me, fine by me. Because again, the patient's happiness and functional recovery is actually the more important thing.
It's all for the best, in the best interest
Yes.
of the patient.
Yep.
Thank you very much, Prof. Azlina and Prof. Nahar, for this part 1, where we talk about the unseen that happens before surgery. And now, we have to remember or bear in mind that going into surgery is a very scary or daunting feat. Now, whether you are a patient or you're caring for a patient, let's do all that we can to ease the process, to ease their journey, and make the process a lot smoother. Now, with doctors like Prof. Azlina and Prof. Nahar, I think the patient has an excellent team. They are all in good care, in good hands. And so we will talk more about the recovery process in part 2. Stay tuned. Before that, don't forget to QRate us by subscribing, following, sharing, commenting. So yes, stay tuned for part 2.
Did you enjoy today's curated episode? Well, don't forget to tune in for the next episode of Curated Podcast by UMSC. To learn more about our consultants, specialties, or to book an appointment, visit umsc.my. For health tips, behind-the-scenes content, and expert insights, follow UMSC on Instagram, Facebook, TikTok, Spotify, and Apple Podcasts. Till next time!